decisions will have to be made regarding the need for prophylaxis. And this particular thing about making decisions is not something that one could take lightly. It should be taken only after a lot of careful thought, because once you start prophylaxis, your treatment is likely to be for quite a significant length of time. The indications for prophylaxis um, will be on the next slide. These are well known. I don't think I need to go into great deal of detail on this. It's going on from chronic persistent asthma, following severe life-threatening attacks, frequent episodic asthma, significant loss of schooling due to asthma, obviously because schooling is very important for children. Exercise-induced asthma, all children are active, and their activity will be truncated quite a bit by the occurrence of exercise-induced asthma. And also, when they have troublesome nocturnal cough and asthma, it interferes with sleep, and we all know how important sleep is for any person, and also how much more important it is for children. Recent increase in frequency and severity of asthma also is given as a reason for starting prophylaxis, because once the occurrence of asthmatic attacks starts to increase in frequency, the chances are that it will go on and go on increasing in a sort of in a manner, unless you really deal with it. The last one, number 8, is inaccessibility of medical care and for social reasons. These are not generally given in many of the guidelines or any of the papers on asthma. I have put this in because this is particularly relevant to Asia, and particularly relevant more so to a country like ours. Inaccessibility of medical care, especially at night, because many of these severe attacks tend to occur at night. And if they can't get to a medical facility, the chances of the child dying are that much higher. So, to summarize all these, it is really a situation where there is interference with the quality of life for the child. And that is the reason that one would think of all these things as indications for prophylaxis. What is the unequivocal indication for prophylaxis as indicated by the Global Initiative for Asthma, or GINA guidelines? Very simple. It's poor control of the disease. Because poor control of the disease interferes with the normal lifestyle of a child. When you look at prophylaxis, as it would come in the next slide, there are so many things that that can be included in the types of measures that we can take for prophylaxis. One is inhaled corticosteroids, and that is the cornerstone of prophylaxis for the treatment of asthma. And inhaled corticosteroids per se, as individual drugs, ones that could be used, and also now we have combination inhalers, that is inhaled corticosteroids with long-acting beta agonists. And you have leukotriene receptor antagonists, you have immunotherapy, anti-immunoglobulin E monoclonal antibodies, theophylline, temperature control laminar airflow machines, which is something very new, and also lastly biologic agents that could be used. Now, many people believe that inhalation therapy with corticosteroids is the cornerstone of asthma prophylaxis. This is basically true, and it has remained true for quite a long time. But we think that inhalation therapy is new, but is it really new? I would not say so, because this was known even as far back as 600 BC, or before the Common Era, that Sushruta, the great Indian Brahmin physician, used this as inhalation of dhuma produced by burning medicinal sticks, which he called vati. So this was known, and also you might be surprised to learn that in the 19th century, the beginning of the 19th century, inhaled drugs for asthma were sold as cigarettes, and these actually contain atropine and hyoscine or scopolamine, because they all have some bronchodilator effect. Now, what features actually determine the effectiveness of inhalable steroids? Because I said that is the cornerstone of treatment. Now, all these things are like topical anti-inflammatory action. They should be able to work on the surface of the airways for us to get the maximum effect. And the quantum of the lung deposition, the binding affinity to glucocorticoid receptors, the lung residence time, or the time for which the drug remains within the lung, the potency of the drug, and the metabolism of the drug. These are all very important features that determine the effectiveness of all inhalable steroids. Now, if you look at the pharmacokinetics of any inhaled steroid, um, what actually you see on your slide is that whatever you do, whatever the device that you would be using, the maximum amount that you can get as deposition in the lung is 20%. Quite contrary to popular belief that it is just about 20%. And about 80% gets swallowed. And through all these mechanisms, quite a reasonable amount of this gets into the systemic circulation. But if you use it in normal standard dosage, the amount that goes into the systemic circulation is almost negligible. However, if you have to use high dosage, there you will find that larger amounts will get into the systemic circulation. So this would necessarily need to be taken into consideration when you are thinking of using high doses of these drugs. Now, the first inhaled corticosteroid that was discovered and patented in 1962 is beclomethasone dipropionate. It has been marketed very widely in the early 1970s. The second one that came through is budesonide, which was patented in 1996. And then came fluticasone, mometasone, cyclophosphamide, which are a little bit more potent. And also the last one, cyclophosphamide, is a rather unique drug where it is converted to the active metabolite, which actually works only in the lung, so that your chances of getting systemic effects are that much reduced or almost negligible. The devices for inhalation therapy, there are a very large number of these devices. More than 50 different inhaler devices with over 20 ingredients are in use, and perhaps there may be many more to come in the future. And as given in the journal in 2004, Respiratory Medicine, inhaler devices are likely to become more important than the development of new drugs in the near future, because we cannot think of a groundbreaking drug coming as a form of treatment or a preventive drug for asthma in the near future. About the particle size, that becomes quite important when you talk of inhalation therapy. And here is the graph or a table showing you the different particle sizes. Now, if the particle size is more than 5 microns, that you get a lot of regional deposition in the mouth, pharynx, and esophagus, and it may not really be useful from a clinical point of view. The real particle size that is required as an aerosol is 2 to 5 microns, where the drug actually reaches the upper and central airways. So you do get a clinical effect, and subsequent absorption from the lung is there to a certain extent because it goes to the deepest parts of the lung. And when it is under 2 microns, it actually almost behaves like a gas and may reach the peripheral airways and alveoli, but you might get some local clinical effect, but there is a high systemic absorption rate. Um, However, people are now working on this under 2 micron particle size to see whether they can get that to actually work on the deepest parts of the lung whenever it's required. Now, it's imperative that we choose a device that is best suited for the child, and that also means that you have to take time to train the child. It takes just only a few minutes. Children are very rapid learners, and it's quite easy to train some of them, and especially when they see a new device which is almost like a toy for them. Of course, you shouldn't allow them to play around as much as they would use it as a toy, but you can actually get around the child and teach them how to use the equipment properly. It's somewhat important to put a date on each uh, um, the canister or the meter dose inhaler, because there are only a finite number of doses in each canister. But of course, this has been changed a little bit now with the built-in dose counters. But it is always necessary or desirable to put the name on the canister that when you start using a new canister. Cleaning of spaces becomes very, very important. I think the parents have to be told how to very gently clean it with soap and water or a detergent, and not to scrub the inside of the spacer uh, uh, quite vigorously, because it interferes with the lining of the spacer, which is crucial for their actual activities. And obviously, once you have done this and started the child on inhale therapy, that you will have to check the inhaler technique regularly. This is very important. Possibly every time that you see the child, that it would be better to check the technique. The biggest driver of asthma control is actually the ability of the child to use the inhaler device properly. And also, compared to that particular statement, obviously the most expensive inhaler is the one that is not used correctly, because it doesn't give you the desired effectiveness. Now, choosing a particular device for children who are under 3 years or going even up to 4 years, you might need a pressurized metered dose inhaler and a spacer with a mask. It's important that this mask is kept very firmly on the face to cover the nose and mouth, which may be a little bit unpleasant for a young child, but it is necessary, because if there's an air leak around the mask, that the drug may not reach the deepest parts of the lung where you really want it to go and work. But having said this, under 3 years and up to 4 years, if you try hard enough, quite often you can get very young children to use a pressurized metered dose inhaler and a spacer through the mouthpiece of the spacer without having a mask. And the youngest patient that I have had who could be easily trained to use a pressurized metered dose inhaler and a spacer without a mask, the one that I have had is 2 years, 3 months. So it depends obviously from child to child. In the older children, pressurized metered dose inhaler with a spacer with a mouthpiece would be the device of choice. There are dry powder inhalers. For some reason, the children don't actually like these dry powder inhalers. Um, they get probably the powder actually going in, they feel it in their mouth, and they don't like it. And really, it has not caught on very well in the pediatric setup in Sri Lanka. If you have to use higher doses of steroids, which will be required only relatively rarely, you have to always use a spacer because that will trap some of the bigger particles. It is important that you use and train a device which the child likes best and finds easiest to use. So this may be a trial and error phenomenon where you have to decide on which device that you have to use. Now, spacer devices, now this is just a list of some of the work that we have done. Um, and it shows that about the age groups and how they can use the spacer very well. There are no problems with this. Now, are inhaled steroids efficacious and cost effective? This is one of our own studies on the efficacy and cost effectiveness. It was published in Archives of Disease in Childhood. Um, there were 86 consecutive children recruited over 4 years from 1990, and it was done in the private sector because at that time these drugs were not available through the Ministry of Health. They were randomly allocated to either beclomethasone dipropionate or budesonide. 80 responded well, so that's a very, very high percentage. And our conclusions were that this study clearly demonstrated the clinical efficacy and cost effectiveness of inhaled steroid prophylaxis in moderate to severe childhood asthma. And what is most important is that the cost of illness, the direct and indirect costs of the illness, even taking into account that the fees that they had to pay for private consultations, the cost of illness was reduced by as much as 83%. And this is the first time it has been shown in the world that there is such an advantage by the use of inhaled steroids in childhood asthma. Now, what about combination inhalers of inhaled corticosteroids and long-acting beta agonists? Are they useful? When will you use them? Now, normally these are used up to now in step 3 of GINA and British guidelines, and these are some of the papers, the initial papers that actually have shown the effectiveness of the combination inhalers. Now, many aspects have been looked at. I don't think we really need to go into all the details. And this is another one where combination inhalers were found to be very useful. The addition of the long-acting beta-2 agonist reduced the rate of exacerbations requiring systemic steroids. It improved lung function, symptoms, and use of rescue short-acting beta-2 agonists like salbutamol. Now, combination inhalers, there is this maintenance and rescue therapy with budesonide and formoterol. It was initially called SMART regime, but now it's referred to as MART regime because the S is for the trade name of the budesonide formoterol combination. Now, the initial work in 2006 was done by Visgard. It uses budesonide formoterol for both maintenance and as needed symptom relief, basically. And they showed that this can be used both as prophylaxis and whenever and if ever a child got exacerbation, that they could use the same thing because formoterol is a relatively more rapidly acting, long-acting beta agonist. So therefore, it could be used as a reliever as well. Is bronchoconstriction related to airway remodeling? Now, this is a paper that came in the New England Journal of Medicine in 2011, and their conclusions were that bronchoconstriction per se, even without additional inflammation, tends to induce airway remodeling in patients with asthma. So obviously, these have implications for management. Now, if you look at the microscopy of an airway, on your left there is a normal airway with a reasonably sized lumen in the middle, and the asthmatic airway. You can see how much the lumen has been reduced in the asthmatic airway, and this is due to airway remodeling, and this remodeling occurs by thickening of the mucosa, hypertrophy of smooth muscle, and new blood vessel formation or angiogenesis. And remodeling is the one problem that one needs to prevent, as it is likely to lead to chronic obstructive pulmonary disease, because once remodeling has occurred to a reasonable degree, that it becomes irreversible. One of the hallmarks of asthma is that it is a reversible process, but once it has been allowed to progress on to remodeling, that you are not going to get that much of improvement by relieving the bronchoconstriction. Are combination inhalers safe? There were some concerns about whether they were quite safe. Now, these paper from New England Journal of Medicine in 2016, which showed very clearly that it significantly reduced the serious asthma-related events. Now, once a child is started on inhaled steroid, this is asked very frequently, is it forever? Because we know that in adults, when you have to use prophylactic treatment for asthma, very often it is almost for life. Is it the same in asthma in children? Once again, this is the same study that I showed earlier, where 86 consecutive children were recruited over 4 years. What we did was we actually, once we finished the expenses, allocating that part of it and then publishing it, we continued to observe and follow up these patients. And 80 who responded well were followed up to the end of 2003. That's a period which ranged from 9 to 14 years. And we slowly back titrated and withdrew the drugs. After 1 year of good control, then they were tailed down and back titrated very, very slowly, dose reductions being made once in about 3 months. And we managed to successfully withdraw them in 73. In 7, obviously, we were not successful. We had to revert back to the drugs. And they have been followed up for an average of 8 years with a range of between 9 and 14 years. And this is the first time that this has ever been done in the world, because nobody has been able to follow a cohort like that for such a long length of time. 2 only relapsed and needed restarting of inhaled steroids. That is 2 of the 73 in whom it was successfully withdrawn. So our conclusions were that it is possible to gradually withdraw inhaled corticosteroids in the majority once good control has been sustained on a maintenance dose for a considerable period of time. As for treatment and control, current medications, we can get control in over 95% of patients. And if the control is suboptimal, before changing inhaled therapy, you need to check whether the correct medication has been selected, whether the correct device is being used, whether the technique is satisfactory, and whether the compliance is optimal. Now, this is the thing that is available in Sri Lanka. What I mentioned earlier, meters dose inhalers with dose counters. Now, when you look at these dose counters, now this is a magnified image of the actual counter itself, which is there in the inhaler. But what I always tell the patients is combine this with a written note of the day in which it has been started, because that will be a cross check on your dose counter, because we cannot always rely on these dose counters. So there is a cross check on that by the actual date being written on this. The next drug is Montelukast, Eucharine receptor antagonist, which was patented in 1998. Is it useful? I will just rush through this because these are all sort of papers in which it has been very clearly shown that they do have a place in the prophylactic treatment of school-age asthmatics. It is also used as add-on therapy. only in very few that it can be used as standalone treatment, but it is most often used as additional treatment to inhaled corticosteroids in step 2 and 3 of GINA guidelines. And really, there is no agreement on which one is better as add-on therapy, whether it's Montelukast or a long-acting beta agonist. But now the balance of opinion is moving more towards long-acting beta agonist for a start when it is combined with the inhaled corticosteroids. And then Montelukast would come in later if necessary as add-on therapy. What about the use of Montelukast with combination inhalers? That is, inhale corticosteroids, a long-acting beta agonists all combined in the same inhaler, and to that you need to add Montelukast if you want better control. Obviously, you would think of adding this Montelukast to your combination inhaler only if combination inhaler cannot give you satisfactory control of the disease. There are hardly any studies that have been done in this respect, only anecdotal reports on difficult to control asthmatics, but it is possible to get better control at lower dosages of combination inhalers. And from a personal point of view, I have found this to be a very useful combination. Although technically, scientifically, there aren't that many studies that have been done in this respect. What about immunotherapy? Is it new? Immunotherapy has been talked about. It has been there for more than a century, actually. And systemic immunotherapy may be administered in two forms. One is subcutaneous, the other is sublingual. Subcutaneous was a bit of a problem when it was really started. I think this entire thing of immunotherapy started with subcutaneous administration because of the risks of developing allergic reactions and heightened sensitivity reactions like anaphylaxis. There are a large number of trials with several meta-analyses which have shown that there is a place for immunotherapy in the management of childhood asthma. This particular study, 5-year follow-up on preventive allergy treatment or PAT study, showed that over a 3-year period when it has been used, standardized allergen extracts of grass and birch, which showed long-term clinical effect and preventive effect on development of asthma in children with seasonal rhinoconjunctivitis. But of course, together with this, they also showed that there was improvement in asthma as well. There was a meta-analysis of immunotherapy on sublingual immunotherapy with standardized extracts which showed very clearly that it is useful. But one thing is important, that this can be used only when we know that the asthma is precipitated by very specific allergens. Now, anti-immunoglobulin E monoclonal antibodies have been used, and this was one of the first studies in 2009 which showed that add-on omalizumab, which was the original compound that was used, is effective and well tolerated as maintenance therapy in children with a type of asthma which is even very difficult to control with the other forms of treatment. So this is a fallback form of treatment. This is not a thing that you would use straight away as a first line treatment. When things are difficult, when the child is not controlled, that these are the sort of third and fourth stages in which that this would come in. Now, these are some of the studies that have been done which show that omalizumab is, of course, quite effective. One thing about a drug that I would like to talk about very briefly is many people use theophylline as a prophylaxis. At least some of the studies, quite a lot of the studies that have been done on the use of theophylline as prophylaxis has shown that it has failed to show a beneficial effect or immunomodulatory effect when used in low doses. And the results, the authors go on to say that results do not support a more important role for theophylline in the long-term treatment of moderate childhood asthma. And if you look at the Cochrane review of theophylline as a form of prophylaxis, which was published in 2006, it again showed that they are less effective than inhaled steroids and have a less favorable side effect profile. There is insufficient evidence at present to assess their role as add-on preventer treatment when compared to the newer alternatives that are available. If at all, if at all, that if we have to use theophylline, it may be tried if symptoms are not adequately controlled on optimal therapy with other agents, or that they may also be tried for troublesome nocturnal symptoms when the child is otherwise well controlled during daytime. Now, I must stress that these would be extremely few in number. Ketotifen, a mast cell stabilizer with antihistamine activity. This is a drug that has been frowned upon a lot in the Western Hemisphere because they are not at all convinced. They don't even mention that this drug has some place in the use in their use in prophylaxis. However, many studies from the East, especially from Japan, show that it is useful. And a Cochrane review in 2004 has gone on to state, now this is a Cochrane review that has been done in the Western Hemisphere. They looked at all the literature that was available and have come to the conclusion that alone or in combination with other drugs, it improves control of asthma in children. Now, what about the place of combination inhalers plus leukotriene receptor antagonists and ketotifen, all in combination? There is no work done at all on this because when it's pretty difficult to control the disease in some children, that it may be necessary to use many drugs in combination for this. From a personal practice point of view, I have been using this in certain selected patients with pretty good results. What I mentioned initially in the list, a recent non-pharmacological strategy is where there is temperature-controlled laminar airflow, which delivers filtered, allergen-free and particle-free air to which is showered to the patient's breathing zone at night when they are sleeping. This filtered air is cooled to 0.5 to 0.8 degrees centigrade below the room temperature and slowly expelled onto the patient's breathing zone. And the machine can be easily kept by the bedside while the patient sleeps. And there are several studies of placebo-controlled clinical trials which have shown that to be safe and effective in reducing symptoms of asthma. Obviously, this is again a device that would be used in very severe asthma where it's difficult to control them with the other drugs and measures that I have already mentioned. This is a picture of the machine under which the child sleeps and then has a good night's sleep, and this has been shown to be very useful in the control of extremely difficult to control asthmatics of this age group. Now, there are, especially in the Western Hemisphere, very severe refractory asthma. Very rare. It is a real problem in those countries, and even if we get them here, it will still be a considerable problem. And identification of these patients will obviously help in treating them, initial identification. And they are mostly severe recalcitrant asthma with a very marked T helper cell 2 type of endotype of severe eosinophilic asthma. Now, what has been found and published in 2018 is that there are increased levels of a protein called periostin in the airway of these children. You cannot do this test on the peripheral blood because periostin in the peripheral blood is also produced through some other metabolic processes in other organs. So if you really want to look at this, you have to do a bronchoscopy and get bronchoalveolar lavage fluid. Uh, these patients, obviously, the reason why one may have to go to all this extent to do this is that if they are detected, they may need biological substances for adequate control of their disease. Having spoken about biologicals for asthma, I already mentioned about anti-immunoglobulin E or omalizumab. Uh, and the reason why I have underlined the last three letters in this MAB, MAB, they are all called whatever the first bit followed by a MAB is because they are all monoclonal antibodies. And there are a whole load of others that which are in trial processes and also in some are being used now with uh, anti sort of cytokine types of these things, where I have given all those names. It's not necessary for you to remember any of these things. None of these things are available. But what needs to be remembered is that all need to be given parenterally and they're extremely expensive. And IL in this stands for interleukin. So you have anti-interleukin 13, anti-interleukin 4, receptor alpha, all this kind of thing that I have listed there. Why is optimal control of asthma so important? Um, this is a study in the New England Journal of Medicine in 2016, which showed and they concluded that children with persistent asthma have reduced growth of the lung functions and are at increased risk for fixed airflow obstruction and possibly chronic obstructive pulmonary disease in early adulthood. Now, this is a slide that you saw about the microscopy of the airways. On the left, the normal, and on the right, the asthmatic airway, where it has been narrowed quite significantly. What we want to do at all costs is to prevent this type of remodeling of the lung. What are the essentials in all forms of prophylaxis? The regular evaluation is vital. Aim is to get control of the disease, and there are different rates of control, like controlled, well controlled, partly controlled, uncontrolled, and with exacerbations. And vast majority of children, it has to be stressed that with asthma, could be very well controlled on the drugs available in our current medical armamentarium. Uh, if you look at the GINA guidelines, now the entire process of control of the disease and prophylaxis is now based on how good the control is. Now, this is the cycle on which it works, that you have to constantly review the response, assess how good the control is, and adjust treatment. And this is a continuous cyclical process that you have to undertake that as you go along. So this is why I said that once you start prophylaxis, that you have to keep on observing these patients, keep on assessing them. I've seen very often even consultant pediatricians have given inhaled steroids, and then really the children have been carrying this on and they have not made arrangements to follow them up very carefully. But this is necessary. And there is a GINA assessment of symptom control. Four simple questions. Daytime asthma symptoms more than twice a week. Any night waking due to asthma. Reliever needed for symptoms more than twice a week. Any activity limitation due to asthma. And well-controlled ones, none of these are positive. Partly controlled, 1 to 2 of these may be positive. And uncontrolled, 3 to 4 of these may be positive. So it's a very simple way of assessing control. Now, stepwise control of children 6 to 11 years, the GINA guidelines of 2017, they go from step 1 to step 2 to step 3 to step 4 to step 5, depending on how well you are going to control the situation with all the forms of treatments that I have already mentioned. So they have preferred controller choice, where in step 2 there is low dose inhaled corticosteroids, going up to low dose inhaled corticosteroids with long acting bronchodilators or beta agonists, and step 4 medium and high dose inhaled corticosteroids with long acting beta agonists, and then step 5 is if you cannot control with any of these, that you need to refer for add-on treatment, highly specialized add-on forms of treatment. And for reliever, you have as needed short-acting beta-2 agonists being needed for this. But in step 3, 4, and 5, in 2017, they also added the low-dose inhaled corticosteroids with formoterol, which I mentioned earlier, something similar to the SMART regime or the MART regime, where the same inhaler can be used for prophylaxis as well as as a reliever. Now, they also added in 2017 the sublingual immunotherapy, and also that they have highlighted this last bit of lines on this thing, and I have magnified it here in this slide. Said consider stepping down if symptoms are controlled for 3 months and they are at low risk for exacerbations. And also they have mentioned that abrupt ceasing of inhaled corticosteroids is not advisable. Now against this, that in our 14-year follow-up study, which has not been replicated ever because people have not been able to have such a cohort being followed up for such a long time, the dose reduction was commenced only after 1 year of adequate control. Certainly not 3 months, much longer period that you have managed to keep them under control, and then back titrated at 2 to 3 monthly intervals very slowly. And I believe, and many people believe now, that this degree of progress of the reduction of the dosage is the one that we need to employ to get better results. And that is probably why we were able to withdraw the drugs without a recurrence of the disease in a very, very large proportion of patients. Now, if you look at the GINA 2019, that is just last year, that is the revised edition that came out, that they have gone to the extent of putting inhaled corticosteroids and formoterol right from the start, from step 1 onwards. Rest of it has remained more or less the same. So instead of just only the inhaled corticosteroids per se, they have always started with the combination inhaler containing formoterol, which can be used as a prophylactic as well as a reliever. Now, this is one big change in the GINA guidelines. Now, here I have highlighted where the formoterol has come in. It has come at all stages from step 1 to right up to step 5. The goals of long-term prophylaxis are what are given in this slide. Achieve good symptom control, maintain normal activity, that is everything that you try to give them a normal life. So there are no daytime symptoms, no nighttime awakening, all this kind of thing that has been listed in this slide, and with very good normal lung function on spirometry if you have to do it, and none or minimal side effects obviously due to the medications. Now, when you talk of prophylaxis and guidelines, do people actually follow the guidelines? Now, these are two studies, one in the United States of America and the other in the UK, where they looked at insurance statistics and the prescribing habits of consultant pediatricians in the two countries. And it showed very clearly that they don't actually believe that these people are sticking to the guidelines. I'm very pleased to see these two studies because I'm one of the earliest people who started using combination inhalers very early on in children, and I think I have now been vindicated by the development of the most recent guidelines on the very early use of combination inhalers with inhaled corticosteroids and long-acting beta agonists. It was Professor David Lawrence Sackett, the father of evidence-based medicine and the founding father of the Cochrane collaboration, who once said that half of what you learn will be shown to be either dead wrong or out of date within the next 5 years. The trouble, he said, was that nobody, not even your teachers, can tell you which half of it will be. So what he said was the most important thing is to learn how and to learn how to learn on your own. And this is quite true in the management of asthma and prophylaxis. Things have changed. Now you can see how much the combination inhalers are coming into force as virtually a first line form of treatment for even mild forms of asthma. Ladies and gentlemen, I think our aim in the control of asthma is to give them a normal life. We let them fly through the air, right, and live a normal life. And this obviously means that we'll have to go at it with a lion-hearted response. Now, here are four people that I have listed the names. Ian Botham, one of the greatest all-rounders in cricket that we had. Alison Streeter, the great swimmer. Paula Radcliffe, the marathon runner. And the lady who was known as a superwoman, Jackie Joyner Kersey, the crack athlete of yesteryear. All four are very bad asthmatics. And they have reached the absolute pinnacles of sports, even with the disease, because they were pretty well controlled. So just to show that it can be done, it only needs a lion-hearted response. Ladies and gentlemen, I have given you some of the well-known stuff about prophylaxis and some of the more complicated material as well, and even some of the more high-powered finer points of the game as it is today. Thank you very much